My apologies for that. I am still not totally certain on what was going on, but can we see that?
Yeah, I wouldn't be able to talk the whole time because it's echoing and it's making the.
Yeah.
Oh, I guess now it's like solid, but it was echoing.
Yeah. All right, that's the magic. Well, let me just get started and appreciate your patience with getting that going. And Jewel, I'm sorry. I know we tried to work really hard to minimize any type of difficulties there, but that's kind of life, I guess. And so um, it's very nice to once again be presenting at the University of South Dakota. And I'm here to just kind of discuss financial components of healthcare. My name is James Preston. I graduated with my MBA in a health service administration specialty a couple years ago. And at the moment, I am employed by a federal contracting company called Federal Advisory Partners. And so I am broadcasting from our office here, and we are located in Arlington, directly west of the nation's capital. So I don't know if anyone was able to see the National Mall behind me, but we're kind of really in the thick of all the decision making of what's going on with particularly the Veterans Health Administration and the Defense Health Administration, which together make up the largest integrated healthcare system in the United States. So we as consultants and contractors work underneath a number of different contracts where we have partnerships with some large accounting firms, such as Guidehouse, which is a part of PricewaterhouseCoopers, and we work alongside Booz Allen Hamilton. We subcontract out to Grant Thornton, which is another major contracting firm, and a number of other different partners. Our main clients are within the Veterans Health Administration and the DoD's Defense Health Administration. But my job really is to help in the revenue and operations of what's called the community care transformation. And I'll discuss a little bit more about that later on, but what it is a bill called the Mission Act, which was actually written by John McCain, Daniel Akaki, and Samuel Johnson. So it's a bipartisan bill that was signed into office, or signed into law, excuse me, back in June of 2018. So these regulations are really what guide most of what we do in the healthcare sphere. But to stay kind of pertinent to what everybody is studying and what they need to keep in mind is these cost aspects of healthcare. And I really would like to keep this fluid and answer any questions or help guide conversation when it comes to the actual the delivery of care, but give it in a way that is a health administrative sort of perspective. So healthcare costs, we consider them almost financial barriers to access. And co-payments, for example, are something that would not necessarily be thought of as being a very controversial issue, but co-payments are a creation by the insurance companies to help share the cost amongst patients and the payers. So in health care, obviously we have the doctors, right? So we have our providers and we have our patients, and that's really the gist of it. Yet as a society, we have decided to get incredibly complicated with the relationships between the patient and the provider. So this creates a lot of opportunities and also a lot of restraints to how we provide care. So the barriers, let's see, access to care remains one of the biggest issues in health service administration in the US, because whether manipulated or organic, the American healthcare system operates within an influence of rationing and scarcity. So we only have X amount of physicians and we have Y amount of patients, and X is always going to be less than Y, and henceforth the scarcity and the rationing. That's why we now have this big push towards urgent care, so that we do not overwhelm emergency rooms, and we can try to essentially maintain that rationale of care. and we just live in a market of scarcity. I mean, that is essentially the markets of the world. They're all involving scarcity, but healthcare is certainly no different. And unfortunately, oops, I'm sorry, getting a call here. But American healthcare is certainly not impervious to those types of economic barriers. Costs, well, so when we think of costs, I was thinking, you know, obviously money and financial costs, but I believe that time is actually somewhat more of a valuable currency than money at times. And so we all want more time, but we can't really necessarily quantify it. But time when we go to see the physician is a big cost, and also not to think about the subsequent referrals and all the care that goes along with that. We have opportunity costs. We have, which is, you know, the foregone opportunities that we spend when we are seeking out care. Costs can be rationalized in quality, costs of rationing of care, and some of these other things that we've talked about. And I have on here value-based purchasing versus volume. It's big, probably discussion amongst your studies right now about this value-based purchasing push. That's not going away, and it's another way of sort of filtering out unnecessary treatment options, so to speak. So in the past, you know, providers were really incentivized to see the most amount of patients as possible, and they would just kind of like you know, grind out all sorts of bills and charges and make their money through volume, but it wasn't really doing much about the overall expenditures as a country. So obviously this value-based purchasing has become a big hot item here, and that's not going away. This is a little statistic from just 2011, so 8 years ago. You can already see at that point the runaway expenditures that we have in the United States, next being Norway. I believe when I was studying at USD, it was Great Britain was the second largest spender, and that was in 2015. But we're going on to today, you can see that that cost has increased by 40% in just simply 7 years. So there is no real slowing down when it comes to the amount of expenditures that are being driven into this this field and this industry. So what that does is it creates a lot of opportunities for people like myself and like this company, and definitely independent businesses that are out there to try to integrate systems so that we can eliminate the extraneous waste that occur. And what the Veterans Health Administration has really found is that by standardizing processes across the board, they're able to save billions of dollars in the long run. And right now we are in a phase where I believe scholars will look back at this time and realize that it was in such a rapid growth period that there was no standardization across even internal systems. There's multiple different electronic health record systems being used in some types of systems, and the fact that they don't communicate well with one another creates great waste. It's a danger to patient safety, and ultimately a large growing pain. So the increase in costs, and why are we approaching constantly that increase in spending? Well, you know, speaking with some of the other folks in the office about this question and the professionals in the field, we have a lot of different, that's revenue cycle, but we have a lot of different regulations that are coming in to affect healthcare right now that are really important to be very aware of. If you go back to 1965, it was the Social Security Act, which created essentially what we know today as Medicare and Medicaid. Title 18 and Title 19 of the Social Security Act is something that, you know, we as, you know, a country and politicians decided to pool our resources together and protect the vulnerable, which is a part of essentially, you know, as a society, a positive thing. And I believe bipartisanly that's been proven to be very much an agreed issue. But we also have such acts as in 2009, we had the High Tech Act, which was actually part of the, some of us remember the TARP, the big bailout, and that was an incentive for all of us to start approaching these electronic health records and to start forcing providers to adopt parts of these new major health record systems. And that has been proven to become something that will be 20 to 30 years from now before it'll be actually be sorted out. And that's a kind of a conservative guess, but we'll see what exactly will be the ramifications of all that down the road. Recently, we've had the Patient Protection and Affordable Care Act, and that has really drastically changed health insurance in this country. Not health care. It's confused as a health care act when in fact it's a health insurance act. And what it really gives is the essence of that is it allots what's called the premium tax credit. And that is otherwise the subsidies that we know as under the Obamacare. But then this other act that is creating all the work for the space that I'm working with under is the Mission Act, which I briefly mentioned before. And that is what is going to allow veterans to be seen outside of the VA health system. In 2014, some of us may remember there was a lot of national attention, particularly directed at the Phoenix VA facility because they had a numbers of veterans who were actually dying, waiting to be seen. And as a society and under that administration, we decided to, the government passed what's called the Veterans Choice Plan, our Veterans Choice Program. And that began the work, which is now the Mission Act. And that just allowed veterans to seek care outside of the VA facilities and VA health medical centers. So a big aspect in the finance of healthcare, and this is something that it took me a long time to really grasp, and I know this doesn't give you the best visual of this, but revenue cycle is a word that you'll hear in all health systems, and it's a big component to even small private firms because revenue cycle is, think of it just like a cycle, right? It's when the patient comes into the office and it follows the patient even after they've been healed, so to speak, and their last payment is made. So I will work and do work pretty extensively within what's considered the revenue operations side of the revenue cycle within the Veterans Health Administration. But if you are to rationalize how this works, and you can think about all the other these little aspects and how many different people have to be employed to fulfill each of these positions, from we have a scheduling, the patient needs care, so he has to be scheduled, he or she has to be scheduled. Then you have to have what's called insurance capture. So someone has to be employed to take in their insurance, make sure that's right. So then they go to, what's called an insurance verification. So you have someone employed to do that. Once the insurance has been verified, in the VA side of things, they have what are called utilization review officers or nurses. These RURs, or revenue utilization review nurses, are looking at veterans, for example, and determining whether they are a service-connected issue or a non-service-connected issue. So without getting too granular into how veteran care is established, it's just another check on the box as to adding into the complexity of what is the revenue cycle. So finally, the patient is seen and diagnosed, and then the provider will document what is needed, develop a prognosis and a treatment plan. And then that plan, which is essentially the girth of healthcare, right? That patient touch experience, then goes off to other professionals that will do what's called coding. Coding is where we translate the patient's needs, diagnosis by the doctor, and the codes into a language that can be read and understood by the insurance companies. So if you think of it, coders are really just translators, and there's an incredible level of complexity that goes in coding. Some of you guys probably have family members or know people who work in coding. There's licensed professional coders actually who are working within these CPTs, and they're the different CDRs, the diagnoses, and that are constantly changing as well. So that's a whole other aspect of complexity. And so then once the codes are sent, then another big problem with healthcare in general is this charge entry aspect of taking the codes and then actually billing the insurance companies. So charge lag is a metric used in big health systems, and days of revenue outstanding is another metric you'll hear. But that charge has to be submitted to the insurance company on behalf of that patient, preferably as soon as possible. However, life doesn't always work like that. And so you have these different time frames, and you're trying to just maximize that efficiency right there, creating an exorbitant amount of work for contractors and consultants as well. So insurance companies, they will receive these charges from the coders, and their job then is essentially, right, to provide, then understand what's an acceptable payment, what will be accepted. And then also the big part of insurance companies is to deny charges as well, right? And maybe I'm a little biased coming from the private sector, but the insurance companies will then somewhat go into a little bit of an arbitration amongst the providers, find out what exactly they do owe, and then eventually, hopefully, they remit payments to the providers. So at that step, the provider then finally gets their check for or their bank deposit for the services rendered, and then they can complete towards the end of this revenue cycle. Now, granted, there is always co-insurance, co-payment, which is the responsibility of the patient, and this is the advent of the insurance industry, because it's important for in the insurance industry argument to have patients have what's called skin in the game, to have some sort of protection against the term moral hazard, right? So they're not just utilizing their insurance for every little reason. So kind of putting a little checks and balances and responsibility back onto the individual. So you also have, after that remittance period, you have bills that will go out to the patients. And those patients, if they make their bill in time, you're about closing the revenue cycle. Yet if these patients have a hard time paying, which is a large case in healthcare for some of these bills, because the costs are in themselves so large, you have a bad debt department, right? You have accounts receivable, and that's where they will collect the collections and have to follow up in any type of regulatory reason thereafter, sending collections to another third party to then pursue that debt. But that's in maybe 5-10 minutes of how long I've just been speaking, the gist of what's a revenue cycle. And the revenue cycle is the essence of the costs that are going involved with healthcare. An important little part of the revenue cycle that I brushed over was this aspect of who determines what the price of care is. Now, the word for that individual is typically called the charge master. And the charge master is referred to as the individual or the people who determine like how much that cold is worth, right? Like, or how much how much stitches are worth, or how much, an injection of, Humira is worth, right? So that aspect also fits within this revenue cycle? And the answer to that question is largely the bills that health services or health systems push down to the patients comes from the CMS fee schedule. And the fee schedule is the list of prices for all services under the sun. If a doctor is going to do it to a patient, there's going to be a code for it. And that typically comes from a combination of both the CMS and another private payer who's kind of seen as the industry lead, which is Blue Cross Blue Shield. Definitely providers love to see patients whose insurance is held by Blue Cross Blue Shield simply for the fact that they are known to reimburse at a higher rate than what would be CMS. And when you say CMS, that stands for the Center for Medicaid and Medicare Services. It's part of the Department of Health and Human Services. And that is really a large driver of what our pricing is in health services. So here is some of these three large bills that I mentioned earlier, and just kind of give you a visualization of why our costs in healthcare are so much. And a large part of that is because it is so regulated. And here you have some of the three largest legislated policies that have trickled down into the cost of care. Obviously, the Social Security Act in itself is not necessarily a cost driver, but it does establish that fee schedule and does have incredible implications. Then you have the HITECH Act, and you have Obamacare, and these are just three of really thousands and thousands. So this is way more complex, but those three, Obamacare, HITECH, and Social Security Act, are really important to have an understanding of. So then I was going to discuss a little bit about the Mission Act, which is the bill that is helping veterans be seen in outside providers. And again, that's maintaining internal systems and strengthening integrated outpatient networks, because no good legislation goes by without an awesome acronym. So this is a little bit more about the Mission Act. And it really did help break the United States into different quadrants of service areas. And they call them these VISNs, right? These Veteran Integrated Service Networks. And within those, we have what are called CPACs, which stand for Consolidated Patient Account Centers. And this is really the billing office side of the veteran services. I'm going to continue on because I want to be able to give people questions or can see where else we can go here. But I did put the slide together about the future state of the Health Services Administration, because it's worth noting that every 4 years as a country, we decide political leadership that may have the opportunity to change drastically or not at all the industry itself. So we'll see what happens there. The increased consolidation, now acquisitions have been occurring across the board. And if you track acquisitions right now, long-term care facilities are the latest target. When I was eaten up back in the day, I was in urgent care, and urgent care acquisition kind of had its peak, and now it's, most of those are all part of large systems now. But long-term care facilities are now on the purview of many large systems. Also, the future state of healthcare, we have these Internet of Things type of discussion and technology. So your iPhone in your pocket is technically like a wearable device that, unbeknownst to you, is monitoring your steps if you keep it in your pocket, right? And so how those are going to help driver behaviors is something yet to be determined, but certainly large tech companies are aware of this and are certainly trying to make small steps into getting into the field. Like where I'm at right now, if I look out my window this direction, I'm actually looking down upon which is called HQ2, and that's Amazon's second headquarters, located in Crystal City here in Arlington. And if you know anything about Amazon, they love automation and they love to do anything that makes money. So there are, it's no surprise that they are trying to enter slowly into healthcare, as is Google. Google has been making some moves in that direction as well. There's a wonderful blog called Modern Healthcare that is something worthy of checking out. And these big tech companies can really act as big disruptors in the economy, or well, in the industry of healthcare. Then I guess, rather than going into all the millions of different EHR, something to take with you is the understanding of the largest players right now in the electronic health records industry, and there's really two. There's Cerner and there's Epic. And Cerner is actually going to be implemented live here in March. Another project that this company and myself are working on is the implementation of Cerner across all of these outpatient facilities and inpatient facilities in the Veterans Health Administration right now. And Cerner doesn't just exclusively utilize public partnerships or clients. They actually do work in the private industry. And the leader right now, or one of their largest competitors in the private industry, is a company called Epic. And I'm sure you guys have heard of Epic before. They're utilized by Sanford. The Mayo clinics use them, and thousands of others. So Epic and Cerner, those are your two big players. So that is all I had prepared time-wise for today. Apologize if that was a big ramble. Healthcare is not an easy topic to discuss, but if anyone has any further questions or would want to connect, I'm leaving both my email addresses and my phone number for anybody that wants to shoot me an email or has any particular question. So at this point, I kind of feel like I've been talking to myself in this big empty boardroom for some time. So please, if Haley or Jewel, you want to get back on and answer a question. Hello? Hello? Hi.
Okay, can I have you mute the speaker on your phone?
Yes. Okay.
Okay.
Alrighty.
Okay, what we might have to do is just talk in the chat room because the speaker is really giving a lot of feedback right now. So if you want to get out of your slides, then I'll come back in and I'll open up the chat room for us, and then we can just type you questions.
Okay, sure.
Okay.
That's a great question. I think I can just speak it. right? I don't need to type the question back, the answer. So the VA, right, it only accepts veterans, and not only veterans, it only accepts eligible veterans. So the public cannot go to a VA hospital and receive care. However, the overall, okay, so this is a great question because it has a lot of different complexities with it. To receive care at a VA clinic, and say you are within the top priority group of a veteran status, okay? So say you were in Afghanistan and you, this is the best analogy. You're in Afghanistan and you're in a Humvee and there's 4 soldiers in the Humvee and you hit an IED. And the driver is the most critically wounded, followed by the passenger seat. And then the folks in the back kind of get away without having, severe injuries. And what you see a lot is that, so the most injured, permanently disabled veteran will become what's called a priority group 1. And then the second most injured will fall within the categories of, it's technically 1 through 8. So if you fall into the highest category at the VA eligibility standards, you will not be charged anything. So the cost, so there's really, other than the salaries paid to the physicians or providers, which the government honestly does not care about. That's just part of operations. There's no cost. However, say you fall into the lowest priority groups of the VA and you're in the back and you get lucky, and these priority groups are also based on socioeconomic standards with how much money you're making. And you go to the VA for say a non-service connected issue, then you will be, first of all, billed your private insurance. And that private insurance, if you have it, will be the first payer. And then the secondary paying will be, say the VA. But every case, it's always different. But overall, the simplest way to answer this is that the bills that the VA would pay to an outside provider is based on that CMS fee schedule that I mentioned earlier. So understanding really well what Medicare reimburses for is really what's going to give you the best idea as to what the VA will reimburse for if you are, obtaining care outside of the VA. There's really no no easy answer to that, but that's a really great question, and that's something that I was kind of curious about myself when I started understanding this network. Yeah, do you got any other? Yeah, let's. Okay. And while you type, let me see if I can show you the Capitol again. So it's such a pretty view. Ooh, where is it? Where did it go? Oh. There she be. There's the Washington. Okay, how efficient is the VA? So if you look at data from patient surveys and patient responses, which is a big part of this value-based purchasing paradigm that we're now living in, the VA is incredibly efficient. And yeah, technically they're nonprofit, but technically they're actually a government-run payer. They're government-run. I mean, if there were ever to be government-run health insurance, socialized healthcare, it is the VHA. The Veterans Health Administration is exactly what that is, what it would look like, and how it operates. Statistics show that, I mean, for example, without, mind you, there's thousands of metrics, but patients typically report excellent care at VAs. They actually have a higher survival rate in some instances, discussing like the metrics such as bed sores. Bed sores is a great metric because it really kind of gives the idea of how in tune to the patients the providers and nurses and medical assistants are. And they have a much, much lower bedsore rate than private hospitals. Now, do they provide all the specialty services? They don't. So therefore, there's some things that the VA does not provide, and you have to access care in an outside facility. But overall, they're incredibly efficient. And the only problem is like the scarcity of providers, right? Getting seen sometimes, we've known that it's been a problem. So those aspects have not kept up with the private industry, but when we bring commercial standards into the government role, they're improving greatly. So they're efficient in the provider care aspect, but when it comes to the business operations aspect, they are incredibly inefficient, and they don't collect on the debt like they should, and create jobs for people like myself in consulting. So that's a good question. Will the VA ever turn into a system similar to Medicare? So herein we must kind of discuss what Medicare is and what the VA is. Medicare is it's a social safety net. And Medicare, granted you're not disabled, only kicks in at the age of 65 onward. The VA now is strictly for veteran care, right? And the VA, mind you too, it's funded through the Department of Defense's Military Construction and VA bill, whereas Medicare is straight up funded through, it's Department of Health and Human Services, and I don't know the name of the bill, the appropriations to go to Medicare. And some of that comes through like the Social Security aspect, and I don't want to talk out of my realm, but I think the VA was the system. The VA is more like insurance versus the system. More like, so VA service is more like insurance versus the system. So the VA is essentially, if you can think of what like socialized healthcare would be, it's both insurance and it's providing care. For eligible veterans, now mind you, there's only 9 million eligible veterans in the United States out of the possible 60 million. So it would be wonderful if, if there were, right, in the perfect world, there would be no insurance involved and you could go to your care and it would be affordable and you wouldn't need to have that insurance. Now, the realities are that, the VA must operate on a budget and must pay their staff as well. So I don't know, I guess the choice program with this question versus she's referencing the choice program. So the Veterans Choice Program, which is sunset now and has become the Mission Act, and well, it's a means of seeking care. And now when we go to the community care transformation, this community care network, then the VA in some regard is kind of like an insurance network, because now rather than waiting for your appointment, if that service is available in the community and you meet the criteria, then that provider, as long as they're in the care network, they will bill the VA, and the VA will reimburse the Medicare rate. So it would be no different than that provider seeing a Medicare patient, if that makes any sense. Hey, you know what? I should have just talked about the VA instead, but But I appreciate the opportunity. It's always an honor. I hope you guys got something out of this, and I really appreciate you, Jewel. Thank you, Haley. I'll close with a pretty view. I'll see if I can show you that again. I just love it every day. Come up here and see it. And then the National Cathedral is over here. Oh, you can see it. Stuff. All right. Thank you, everybody. Bye-bye.